Okay, so now we're beginning the learning plans for the Mental Health and Community Concepts course. So this is Learning Plan 1, Analyze Concepts of Mental Health Nursing. So we're starting with Chapter 1, and all of the chapter readings for Learning Plans 1 through 9 are from the Varkarolas 8th edition, and all of the PowerPoints are divided up into material that is from each specific chapter, so that in case there's something that you're not sure of, you want to refer back to the book, you know exactly which chapter it came from. So, first chapter is mental health and mental illness. So definitely need some background information so that we know a little bit of the basic concepts of what we're talking about. So mental health continuum on page 3 in Varkarolas, they really give a very nice overview of what is a continuum of symptoms. So basically, I have a picture of a ruler here. And that's kind of what the continuum of symptoms is like. So it's very similar to using a rating scale. So I think you're probably all at this point familiar with using a pain rating scale. Usually we ask patients to rate their pain on a scale of 1 to 10. Well, we can actually use rating scales for many different types of mental illness issues, such as we can ask a patient to rate their depression, their anxiety, their suicidal ideation, the strength of their hallucinations, or delusions on a scale of 1 to 10. So there's really many different ways that we can kind of use a rating scale, which is part of that continuum. So the rating scale isn't the whole continuum. So basically, in a nutshell, when we think about a continuum of symptoms, some symptoms can be very, very mild, so on the lower end of the continuum, all the way to the higher end of the continuum, which is usually where we see diagnosable mental illnesses. But on any given day, any of us can be on any part of this continuum. So you might have a really bad day, go through some really bad stress, and you might just be very down, sad, depressed, anxious about a certain situation that's going on. And so maybe you feel on that continuum of symptoms, your symptoms might be pretty high for a period of time. But that doesn't necessarily mean that you have a diagnosable mental illness. It just means that you're going through a period of stress. Most of us, when we have periods of stress like that, and our symptoms might be higher on that continuum, usually we know what to do to kind of do self-care and get enough rest, exercise, eat appropriately, get support from other people, and kind of get ourselves back to our normal level of functioning. People with diagnosable mental illnesses sometimes have a really hard time doing that. So it is really helpful to kind of look at this continuum of symptoms, realize that all of us could be anywhere on this continuum for different types of issues, but that doesn't mean that we all have diagnosable illnesses. And even people that do have a diagnosed mental illness, there are many treatments available for people, so there really should be a glimmer of hope that even people that rank higher on that continuum of symptoms and have a diagnosable illness certainly can lead a fulfilling and satisfying life. But it usually may mean that they may need to stay on medication, follow up with a therapist, and just try to reduce stress in their life overall. Stress certainly increases the continuum of symptoms. So symptoms get worse with increasing amounts of stress, whether you have a mental illness or not. So stigma reduction, that's something that we should talk about, being that this is a class mostly on mental health. This class is a judgment-free zone. So being that you are all online, it is really important to think about other people in the class, and everyone comes from different backgrounds and may have some mental illness issues in themselves, or perhaps in a close friend or a family member. So just to think about being really sensitive in discussion posts when you are answering questions and talking about mental illness, just to be very realistic that it is a problem that many people in our society have, and to try to refrain from saying things that are a bit on the judgmental side. And I know it's difficult depending on what your own circumstances might be. And I know that in talking to students, especially in terms of having family members that have issues with alcoholism or drug addiction, it is very, very difficult sometimes for those students to really kind of come into an understanding of that addiction process because of their own personal feelings and perhaps frustration with those family members. So it might be hard for some of you to really refrain from being judgmental or having strong feelings or attitudes. But those are things that, if you send me an email and, I certainly can maybe help you work through some of those things. But just to be sensitive that everybody comes from a different place and not to be judgmental, because most of our society is pretty judgmental about mental health and mental illness, and many people in our society feel that mental illness is a sign of weakness. It means that the person doesn't cope well, and that they have brought this on themselves. They have a personal character flaw, and they are choosing to be the way they are. And being a mental health nurse for almost 38 years, I know that mental health and mental illnesses do exist, and that people do not choose to have them. But there still is a lot of that judgment out in the world. So I'm just basically saying, let's try to make this class a judgment-free zone and really try to consider different points of view, banish stereotypes that we might have, respect other people's experiences, and fight against that shame and blame. We do like to think that people with mental illnesses somehow did it to themselves, and they should be blamed for their circumstances, blamed for their poor life choices, and that just isn't accurate at all. So I guess I'm just encouraging everybody to keep an open mind, especially if there is a particular issue that you have difficulty with. And again, maybe we can all help out each other in the discussion questions. If you have personal experiences with a particular mental illness, a friend or family member, or your own self, if you would like to self-disclose and talk about that, that would be a great, awesome learning experience for the rest of us. If you don't want to, you absolutely do not have to share any personal information unless you absolutely want to. So sometimes people really like being open with others and teaching them about different aspects of mental health. So if that comes from any of you, I think that would be awesome. But please don't in any way, shape, or form feel that you are obligated to share your own personal or family struggles with mental illness. The other thing I just want to mention quickly too is that if anyone has any particular cultural experiences, that would be great to share too in the discussion questions. I had many students do that in the past, and it is so helpful to get that firsthand cultural perspective. So anytime you would like to share with the rest of the class, that would be awesome. And again, if you don't wish to share things that you feel are personal, you absolutely do not have to do that. So let's talk about some concepts of mental health and basically what it is. So the definition is being able to recognize your own potential to cope with normal stress. Basically, to cope with normal stress and to cope normally with stress. I think it kind of goes both ways. So you can have good mental health and you could cope with extreme stress. So this basically says cope with normal stress. But certainly somebody who is healthy is going to be able to cope with more than just a normal amount of stress. And also just coping normally with stress, that people cope in ways that are very helpful and life-sustaining, and something that's basically part of a healthy lifestyle. So when people cope with stress by taking a walk, reading, exercising, talking to other people, having hobbies, and socializing, those are all great adaptive ways to cope with stress. People that work productively are able to, or go to school productively, are mentally healthy and making a contribution to the community. So you're not just taking care of your own needs, you're looking out for the needs of other people. So traits of mental health, the ability to think rationally, so you're not influenced by false beliefs like delusions that are completely false, communicate appropriately, learn, grow emotionally, be resilient, have a healthy self-esteem, and having realistic goals and reasonable function within that individual's role. So that doesn't mean you have to have the highest functioning possible and never experience a bad day in your life. It just basically means that you have an overall ability to function and to cope effectively and to communicate and live among other people. Again, on page 3 in Barcarolis, there's a very nice table that shows some other aspects of, well, it's not really a table, it's kind of more of a diagram that shows some other aspects of mental health. And they talk about spiritual satisfaction, being developmentally on task, having some self-awareness and self-control, happiness and joy. So there's lots of different things that we can think about when we think about a mentally healthy person. Mental illness now is a disorder with a definable diagnosis, and usually people have significant dysfunction in their mental functioning related to developmental, biological, and physiological disturbances, and mental illness is also culturally defined. So there may be a specific disorder that we don't recognize in our American culture, however, would be considered a mental illness in a different culture. So we do have to recognize that behaviors, moods, symptoms are all culturally defined. Definitions of mental illness actually change over time, and it kind of depends on what's going on culturally and in society at the time, what the norms and values are. So resilience is another concept that we need to think about, and that's the ability and capacity to secure resources needed to support well-being. So resilience overall really means being able to bounce back. So you face adversity, you bounce back. So some characteristics of being resilient would be people who are optimistic, and that doesn't mean unrealistically optimistic, like everything is going to work out great, because sometimes everything doesn't work out great, but it just means that they have a hope for the future that is going to be reasonably comfortable. So having a sense of mastery, being able to be somewhat in control. And we're always not 100% in control of everything that goes on in our life, but to feel a sense of mastery is to feel that we do have aspects of our personality and aspects in our life that we can have some influence over. Whether or not, I really hate to say the word control, because I don't feel like we really have a whole lot of control over everything, over anything. No, we don't control everything, but we do have some control over some things. So just having a sense of mastery, and that we can affect change in our lives. Having a sense of competence, like to say I am a competent person, and even if I'm not perfect, that I can still make a difference in my life and the life of other people, lives of other people around me. And having this sense of resilience really is essential to recovery. So risk and protective factors. So we have individual attributes and behaviors, social and economic circumstances, and environmental factors. So let's look at each one of these 3 bullet points individually. So individual attributes and behaviors. So we all have an inborn style of relating to the world around us. So when you have a baby, or if any of you have had your own children, maybe you have recognized this in your children, or if you have seen other children in your lives, perhaps brothers, sisters, nieces, nephews, you have maybe picked up on the fact that we all have an inborn kind of a inborn style of relating to other people. And that's even apparent as a baby. So some babies are just very smiley, laid back, don't cry a lot, don't fuss a lot. They smile, they're just real happy, happy-go-lucky, just kind of babies that are pretty easy to take care of. And then there might be other babies that are just very difficult. They cry a lot. They are highly reactive to different types of stress. They don't like a lot of noise, or they don't like a lot when there's a lot of people around. They react to that. They cry more. So we all have that inborn temperament. So that is part of our own individual attribute. And that doesn't mean that if you have maybe more of a difficult inborn temperament, that doesn't mean that you're going to be mentally ill and that you're going to struggle the rest of your life. It just means that over time, people that have maybe more of a difficult temperament have to learn different ways to manage stress and to communicate appropriately. So that inborn temperament is part of the individual attributes and behaviors. It is also biologic and genetic factors. So some of us have genetic predispositions. And that, again, doesn't mean 100% that you're going to develop the mental illness because you have a genetic predisposition. However, with increased stress, it's very possible that you may develop an illness over time. So it's not, but it's not a 100% guarantee because you have that biologic or genetic factor. But that is part of our own individual attributes. And our behaviors could be things that we do to modify the effect of stressors. So examples might be just trying to not get into those self-defeating thoughts, but by really, again, living healthy lifestyle, exercise, seeking out comfort from other people. Some people are just better at those types of behaviors than others, so that could definitely be a protective factor. And the risk factor part of it would be the thing that would promote somebody to have mental illness. So people that don't have good resilience and that really have a difficult time seeking support from other people, or if they really wallow in self-defeating thoughts and they can't seem to, to get out of that. So lots of different types of things to think about. So risk factors are things that would promote the mental illness to occur. A protective factor is something that may prevent it from occurring. Social and economic circumstances, so your own immediate social surroundings, so your family is usually the main thing that we look at as having a tremendous effect on the development of vulnerable human beings. So starting with family and then going on to school. So that would be another factor as far as either being something that could be very positive or something that could be very negative. So a risk factor or a protective factor. If somebody has a really difficult school experience, such as being bullied, that can perhaps tip them over the scale into, or think about that continuum again, and perhaps that stress might lead them up the, to have symptoms up that scale, and then they would have perhaps a diagnosable mental illness. People that have really positive social experiences, family and then school experiences, are less likely to have difficulties, and so that would be a protective factor. And the same thing with economics. So people that have families that are able to support them monetarily, they're not lacking for resources, all of their basic needs are met, people are much more likely to have a positive life experience and and less chance of having mental illness than people that have very difficult economic circumstances. They grow up very poor, they don't have basic needs met, and perhaps they're even in very, abusive types of environment and or have experienced neglect. As for environmental factors, on page 5 in Varcarolis, there's a really nice long paragraph. Wow, it's really interesting, some of the examples that they give, so you're going to have to take a look at that. But basically, they're talking about the political climate and cultural considerations and access and lack to basic needs and accommodations like healthcare, water, safety, highway systems. Those all have an impact on mental health. And they really go into having different types of cultural beliefs and attitudes and practices as influencing mental health. And there's no standard measure for mental health because it really is culturally defined. So most of the rest of the learning plans, we are going to talk about diagnosable mental illnesses. And we basically are going on the premise of our own American culture. So, but we do have to realize that when we're taking care of patients of different cultures, that we do have to take that into consideration because there really are very many different ways that our behaviors can be interpreted depending on the culture. So, just a few things for you to think about. All right, case study. So Mrs. M comes to the clinic reporting a feeling of hopelessness. She works full-time and is dealing with a troubled teenage son and her elderly parents. She confides in you that she can't deal with her life right now. So discuss attributes you might screen for to quickly assess her overall mental health. So what would you look for to think about her overall condition? What makes you worried about her in just this little scenario? So some of the things we might want to take a look at, we want to see what are the traits of mental health or mental illness that she might have. So is she thinking rationally, or does she have beliefs or ideas that are delusional, which means that they're actually false, that they're not based in reality? What about her communication skills? Is she communicating appropriately? Is she able to get her thoughts across in a coherent way so that other people can understand her? And can she understand what other people are saying to her? How has she handled stress in her life in the past? Does she have any of those aspects of resilience? How does she feel about herself, her overall self-esteem? That certainly can change from time to time, but usually most of us have at least a pretty constant sense of feeling good about ourselves, although there may be some circumstances in our life that make us temporarily feel a little bit worse about ourselves. A breakup in a relationship or maybe failing a test or something. You might temporarily feel bad about yourself, but you're going to bounce right back into your usual sense of self-esteem. Is she able to function as a wife, mother, daughter, employee? So is she still functioning? Is she able to meet all of those role expectations? Or are there things that right now that she's absolutely not accomplishing because she is so worried about her teenage son and her elderly parents? So as you work through Mrs. M's assessment, you evaluate her possible level of resilience. What other characteristic would you expect her to have if she was resilient? Would it be optimism, patriotism, aggressiveness, or a depressed affect? So I'm hoping that you picked optimism, since we already talked a little bit about resilience. And so we would certainly want to know how she has coped in the past, because that will give us a sense of her being able to bounce back and be resilient. Is she able to use resources to kind of bring her back to her usual level of functioning? So Mrs. M has a history of major depressive disorder. Do we have to deal with that? She says. Can't we just focus on my insomnia? If I could just get something to help me sleep at night, I think I'd cope better right away. Besides, insomnia would be covered by my health insurance. It's an uphill battle getting compensated for any treatment for the other, which she means the depression. Fighting with insurance people is not going to help anything. So basically, in this little scenario, it seems like she really would rather not deal with her depression. It sounds like insurance issues are a problem, and honestly, I know that there are many people that face the same circumstance. So this really is pretty realistic as far as getting insurance coverage for mental illnesses. There are different things that have happened in the past that have helped with insurance coverage. However, we'll talk about those in a little bit. But still, for some people, it really does become an issue, and that might be a barrier for somebody to get the mental health care that they need. So, what causes mental illness? And at this point, maybe you're wondering, I've talked about the continuum and different protective factors, risk factors, but really, truly, it's a combination of so many different things. And it's really difficult to pinpoint to one specific thing. It's not like some medical illnesses where you can kind of pinpoint exactly what caused that issue. So it's very different, a little bit more complex. So we look at the diathesis stress model, and diathesis means the biological predisposition. So usually the genetic predisposition or the imbalance of a person's neurotransmitters in their brain, and then stress. So that would be the environmental stress or trauma. And that is the most accepted explanation for mental illness, that it is a combination of the genetic vulnerability and negative environmental stressors. And those negative environmental stressors really could include just about anything. It could be trauma in somebody's past. Maybe they had a very wonderful life and now all of a sudden, maybe in their 30s or 40s, they're having a great deal of difficulty, or developmental tasks are not being met because of different situations and circumstances in their life. So maybe think about somebody who's in their 60s or 70s and they've had a really great life, and all of a sudden they find themselves widowed and lost their job, and they don't have financial resources, they don't have their partner, and they could find themselves suffering from depression, anxiety, feeling suicidal, those types of things. So a combination of genetic vulnerability and negative environmental stressors. So perhaps if that person I just mentioned who's in their 60s or 70s and all of a sudden has this trauma, perhaps, we do have to look at so many other things, such as what we had just talked about. What is their level of resilience? What is their inborn temperament like? Do they have a genetic predisposition to any type of mental illness? So that's kind of what we would have to look at as far as thinking about their vulnerability to becoming mentally ill. So the assertion is that most psychiatric disorders are a result from a combination of that genetic vulnerability and, again, the negative environmental stressors. So we have social influences on mental health care. So there's lots of different types of movements. I'm certainly not going to be testing you on what each and every one of these different social influences are, but I'm just going to kind of talk about really the first two. The consumer movement and recovery movement really puts the patient in the driver's seat and focuses mental health treatment on where does that person want to be in their life? What are their goals? And really encouraging the patient to be an active participant in their own treatment. The National Alliance on Mental Illness, and the acronym is NAMI. I follow them on Facebook. If any of you are interested in doing that, if you like mental health and you're interested in it, they really post a lot of very interesting, pertinent, up to the minute changes in mental health. It's a great way to keep in touch with the different aspects of mental health that are constantly changing. So that is something. They are very much strong advocates for mental health, and very strong advocates to try to get away from the stigma that is attached to mental health. So the rest of the initiatives, it's great to just read through and think, wow, there really are a lot of things going on socially, politically, that deal with mental health, and all of that is really, really quite good because it's all going to help, promote patients getting the care that they need and not having to experience the stigma. So, and again, also with legislation and funding, just something for you to be just really superficially aware of. The Mental Health Parity Act in 1996, parity means equivalence, and just basically required insurance companies to provide equal treatment coverage for psychiatric disorders, because prior to that, it really was not equal at all. You could really get great insurance coverage for a heart attack, but really nothing for or very little for a major depressive disorder. And perhaps that major depressive disorder was going to take as long as a heart attack for the person to recover from, but the insurance coverage was really quite limited. So that is something that has really been a breakthrough, because people that have mental illness issues can't always afford to pay for their treatment. So having that insurance coverage is really great. The Patient Protection and Affordable Care Act, right now, this is what's in the book, but right now we know that our political climate is changing and insurance is changing. So we really, as nurses, really have to keep in touch with what's going on with insurance coverage for people that have any illnesses, but in this course, of course, we're focusing more on coverage for mental illnesses. So that'll be really interesting to watch and to see how things progress. I'm hoping that it will progress in a good way so that we will have coverage for people that have mental illnesses. The DSM-5. So that is something that we need to think about as far as mental illness, because this is the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition. So mental illness has changed greatly from the first DSM to the DSM-5. So it's been revised that many times. And so our concept of mental illness truly has changed over the years. So what we have now is the DSM-5. I would bet in a few years there will be a DSM-6, and they will take out some illnesses or combine them or somehow change the categories. So again, we kind of have to take things a little bit with a grain of salt, because right now we're using the DSM-5, and that is the official medical guideline for the medical diagnoses of mental illness, of psychiatric disorders, different from nursing diagnosis. So this is the medical diagnosis. We as nurses do not use the DSM-5 to diagnose people. However, we need to be aware of what the criteria are and to fully understand the symptoms that the patients have in their disorders. And therefore, when we know that, then we can work on the nursing aspect of it and use the correct nursing diagnosis and nursing assessments and interventions, and use our nursing process to fully help the person with a mental illness. The other thing I just want to say about this quickly too, I just said nurses really don't use this, but actually advanced practice nurses use the DSM-5 and are able to use this to diagnose patients. Actually, I was able to use the DSM. It wasn't DSM-5 when I was in practice. It was probably the DSM-3 or 4. But anyways, I was able to use this book, this manual, when I was an advanced practice nurse. So people that are in those types of roles are able to diagnose, versus a staff nurse on a mental health unit really does not medically diagnose somebody. So it's based on specific criteria influenced by multi-professional clinical field trials. So not just psychiatrists, but also psychologists and perhaps psychiatric social workers. It lists criteria for 157 different disorders. And the list of disorder categories is really similar to the way the chapters are organized in Varkarolis. So that really helps a lot as far as understanding what illnesses we're talking about. And these classifications classify disorders, not people. So therefore, we should avoid labels and use statements such as a person with schizophrenia. So that's probably one of my pet peeves. is when we call people a schizophrenic or an alcoholic or an addict, because then we make the person their diagnosis. So we shouldn't do that in the medical field too. So we shouldn't say the heart attack, the gallbladder, the GI bleed. We really should say the person with a GI bleed, the person with a heart attack. Same thing in mental health. It should be the person with schizophrenia, the person with alcoholism, the person with an addiction disorder, the person with depression. So that's just kind of one of my pet peeves, is that I really want you also to focus on classifying disorders, not people, and not making a person into their diagnosis. And the other pet peeve I have is when we say things like that are, again, stigmatizing, and we say things like a frequent flyer, and that's pretty judgmental. So we should not be saying things like that. What they've been doing lately on 1K, when I listen to report, is to say something like, this is their 16th admission since the beginning of the year. Well, that's so much better, because that is just very clear factual data, and it's not saying somebody's a frequent flyer is just a little bit derogatory, and it's not as it's more subjective. It's not as objective as saying this is their 16th admission. Okay, I'm going on a little bit here, but anyways, I'm just getting off on classifying disorders, not people, because we really have to remember that a person with mental illness is a person, and they are somebody's aunt, uncle, cousin, brother, father, sister, husband, wife. We kind of have to remember the humanity. Okay, which brings me to psychiatric and mental health nurses. So we promote mental health through assessment, diagnosis, and treatment of behavioral and mental disorders. So we are using the nursing process the same way that any other area of nursing does. So we are just a subspecialty, but we do the same thing that other nurses do, but it's a little bit different. Our focus is a bit different, but we do really pretty much the same thing. We use nursing, psychosocial, neurobiological theories, and research. We work with people throughout the lifespan. So usually, probably not so much think about Erikson stages. We hardly ever work with infants. I don't know of any mental health nurse that works with infants, but possibly, young childhood all the way through older adulthood. And mental health nurses can be employed in a variety of settings and among varied populations. So this is what we do. And this course, really, these basic concepts, we really will think about throughout all of the rest of the learning plans that cover the different types of mental health issues. We will talk about the assessment of people with depression, anxiety, schizophrenia, whatever. We will talk about the nursing diagnoses that we're going to be using and what we do as far as our interventions that are going to be helpful in getting that person to a period of recovery. So we always have to think about NANDA, NIC, and NOC. And so that's NANDA is the North American Nursing Diagnosis Association. So we use approved nursing diagnosis, and we also use approved standard outcomes and interventions. So we don't just pull things out of a hat and think, well, I'll just try this, and that's mental health nursing. Well, no, we really do use standards and things that are, standard classifications and nursing diagnoses. So the levels of practice of a psychiatric nurse, we can have basic level or advanced practice. So basic level would be a psychiatric mental health registered nurse, 2 years of full-time work, 2,000 clinical hours, 30 hours of continuing education, followed by a certification exam, and then you can add add extra initials onto your RN. But you could also just be a new graduate from an associate degree nursing program such as LTC, and you can apply to work on 1K, and you can be a mental health nurse. Okay, I got interrupted there. So anyways, so you can just be a basic psychiatric mental health nurse, and you don't have to have any specific certification. But if you are ever interested, there is certification available in mental health as well as in other different areas of nursing. So you can be certified as a occupational nurse, you can be certified as an OR nurse, med-surg nurse, OBGYN. So okay, just to make you aware that that's something that it doesn't mean that you can't, unless you have 2 years of full-time work and the 2,000 clinical hours and all that, that doesn't mean that you can't call yourself a psychiatric nurse. Okay, anyways. But certification is definitely something that is a wonderful opportunity just to add some extra credentials, even if you don't decide to pursue a master's degree someday. It just gives you a little bit more of an edge as an expertise, having that expertise in your own clinical area. So anyways, advanced practice, psychiatric mental health advanced practice nurse, and that is basically what I am. And you have either a Master of Science degree or a doctorate degree to have an advanced practice nurse. So you can also be an advanced practice nurse who is a nurse practitioner in mental health nursing. So there's really quite a bit of variety as far as the advanced practice. And you can have many different roles. In my role as an advanced practice nurse, I was considered a consultation liaison nurse at a Jewish nursing home before I moved to Wisconsin and started working at LTC. So I did mental health evaluations on patients that were in a Jewish nursing home, and many of them were actually Holocaust survivors. So of course they had PTSD and many different types of symptoms. And so my role was to help them with their mental health and also to teach the staff how to intervene a little bit more appropriately so that the patients were more comfortable. So lots of different types of roles, but just two basic levels, the basic and the advanced practice level. Chapter 2, Theories and Therapies. So theories help us to explain behavior, and therapies are treatments that are based on the theories. So I am certainly not going to hold you accountable to knowing the different theorists and what they taught. Basically, I'll focus on, as I'm talking through this learning plan, I will help you to try to focus on what I want you to understand on this. So we really are just going to do a little bit of an overview and really talk about their relevance to nursing and psychiatric mental health nursing. So that's what's described in this chapter. So Freud. Well, no, I'm not going to expect you to tell me all about Freud and the superego, id, and ego, and all that. But some things that we do get from Freud are the defense mechanisms and anxiety, that they operate on that unconscious level, and they deny, falsify, or distort reality to make it less threatening. So in Learning Plan 2, I have a whole separate learning plan a whole separate PowerPoint on the defense mechanisms that I did separate from the rest of Learning Plan 2. And at the beginning of that, I kind of explained why I did it that way. But anyways, that is absolutely something that we think about in mental health nursing. And the more we understand why people use defense mechanisms and how they use them, it's really going to help us to intervene more appropriately. So we absolutely do use that part of Freud's theory. We don't really do psychoanalysis. It's hardly ever even used by psychiatrists. So we don't really think about Freud's intrapsychic conflict as the reason for mental illness. We again talk about that diathesis stress model. But the other valid tools and concepts would be transference and countertransference, which is described more fully later on in this learning plan. And so I'm not going to talk about it here. I'll wait until it's in one of the other chapters. I can't remember if it was chapter 7, 8, or 9, but anyways, I will talk about it in a little bit. But that does come from Freud, so it is those aspects of Freud are very valid, and we do use those today. Sullivan's theory is really the foundation for Hildegard Peplow's theory. And you might think, okay, who in the world is Hildegard Peplow? She is actually considered the mother of mental health nursing. So she used Sullivan's theory of participant observer and used concepts like mutuality, respect for the patient, unconditional acceptance of the patient, and empathy in developing her nursing theory. So you don't really need to memorize different aspects of Sullivan's theory, but I will be talking about some aspects of Hildegard Peplow's theory that you will definitely need to know. So her theory of interpersonal relationships in nursing. So again, she is the mother of mental health nursing. I actually had the privilege of meeting her years ago in the early 1980s, and I believe she died somewhere in the later 1980s or early 1990s. But anyways, she is truly the founder of mental health nursing, and her whole premise on working with patients is that interpersonal relationship that you develop with the patient. So again, when you're going through this course, think about how this is going to relate to clinical. When you get to the clinical setting and you have your 4 days on the mental health unit, think about how you are going to try to relate to your patient, and developing that relationship is so very important to that patient's healing. So Hildegard Peplow focused on the art of nursing and the science of nursing. So the art is providing the care, compassion, and advocacy, so advocating for that patient to get what they need, advocating for their rights, and enhancing their comfort and well-being. And then the science applies, that's your application of knowledge to understanding a broad range of human problems and psychosocial phenomena, and that we again intervene in relieving the patient's suffering and promoting their growth. Okay, so I just had to look up Hildegard Peplow. She actually died in 1999. I thought it was a little bit earlier than that. But anyways, it's interesting that she was the first published nursing theorist since Florence Nightingale. Oh my goodness, that's really interesting that nursing theorists really kind of have only, most of them have published their works and done their research since 1999. My goodness, that makes me feel old. Well, anyways, the thing to really get from Hildegard Peplow is that, again, that interpersonal relationship is so important. That can make the difference between a patient that is going to be violent and maybe a patient that will end up cooperating because of that relationship that you develop. So it really is a very, very powerful thing. And it does require a lot of difficulty on your part. Well, I shouldn't say difficulty. It's something that requires, it takes a lot out of us interpersonally to put that effort into creating a relationship with somebody who has a mental illness. So, but it is really truly the basis for her theory, and that is the basis for mental health nursing. So she talks about levels of anxiety when we're thinking about relating to that person with mental illness. We have to think about the level of anxiety that the patient has and what types of interventions that we need to perform to lower their anxiety. And the aim is to improve the patient's ability to think and function. So a lot of her theory is based on the premise that people have anxiety, we need to intervene to reduce their anxiety, and that the goal then will be to improve the patient's ability to think and function as a result of our interventions. So we have other types of behavior theories, Pavlov's, Watson's, Skinner's. So we don't need to learn, you don't need to learn anything about those in particular, but just that we do, the implications for nursing are that we do sometimes use those theories in our therapies, and we sometimes modify, or we work with people to replace behaviors. So as we want to take away one behavior, we want to give them another one to try to replace. We can't ever take away somebody's coping mechanism without giving them something to replace it. And also just the way that we manage behavior overall comes from some of these theorists. So behavior therapy then, modeling, operant conditioning, systematic desensitization, aversion therapy, biofeedback, all has roots in those theories. So cognitive theory and therapies. So cognitive theory, we definitely can use some of this in our work as a mental health nurse, just using ordinary therapeutic communication. So we have to think about the dynamic interplay between the individual and their environment, and that thoughts come before feelings and actions. And so if we as nurses can help patients to think about their thoughts, and they may eventually be able to work on changing their behavior. So thoughts about the world and our place in it are based on our own unique perspectives, which may or may not be based in reality. So we do try to help patients when we're talking to them, try to help them to become more reality-based and to become more aware of our distortions. And therefore, when people are aware of those, they can work on changing those and just to relate to other people in their environment in a healthier way. So nurses do use these therapies. So rational emotive behavior therapy, Ellis, aims to eradicate irrational beliefs. So we can, again, just in our therapeutic communication, try to help people to recognize their beliefs, that those thoughts are not accurate. So an example of an irrational belief might be something like, if I say, I really should be honored and esteemed by everybody that I come in contact with. Well, that may or may not be true, right? So that might be pretty irrational. There might be some people that think I'm great, and there might be some other people that don't like me all that well, and I should be okay with that. So that's what that rational emotive behavior therapy would aim to do, is to get that person to the point where they see that that's not rational, that's not realistic, that everyone's going to love them every moment of their life, that there might be times when people might not like them very well, but that they're still okay and everything is going to be all right. And Beck kind of talked about testing those distorted beliefs and to, again, changing the way that people think. Sometimes that makes them so anxious and worried and have symptoms, and therefore the symptoms will be reduced. Maslow's hierarchy of needs. Of course, we all know Maslow's. I probably don't think I need to spend a whole lot of time on that, but just to remember that we're all active participants in life, we're all striving for self-actualization, and that when people don't have those lower needs, they really can't meet their higher needs. So when their lower needs are met, the higher needs are able to emerge. And certainly very, very evident when we're working with patients that suffer from mental illnesses. And especially, when we hear report, when you're in clinical and you hear report and people are homeless or they have very, very difficult or transient living situations, or maybe they're in a group home, they don't even have a place to live with people that they know. Very difficult when they don't have those their basic needs met, or just met in a consistent way. They're struggling for food, struggling with taking their medications, affording things. So when those lower needs are not met, they really can't reach the higher level of being happy, having all that self-actualization that we want them to have. So we really, as nurses, have to take a look at where they're at on Maslow's hierarchy. So we want them to have those safety, belonging and love needs, esteem needs, self-actualization, but of course those very low needs need to be met first. So that's all I'm going to say about that. The biological model focuses on neurological, chemical, biologic, genetic, and how the body and brain interact to create emotions, memories, and perceptual experiences. So the biological model is certainly used more and more in mental health as we're really understanding many of these illnesses are very much brain-based. So we have to consider other influences that play a role in the development and treatment of mental disorders. We talked already about some social, environmental, cultural, economic factors. And so again, we're focusing on the qualities of that therapeutic relationship, understanding a patient's perspective, and communicating to facilitate recovery. So other biologic therapies, psychopharmacology. So that's use of medications to treat psychiatric illnesses. I did not give you chapter 3 as an assigned reading. However, as we are going through some of the other different mental illnesses through the rest of the learning plan chapters, we are going to certainly be thinking about and looking at different types of medications that are used. So you might at some point just want to skim through some of that. So you certainly don't need to memorize about the different parts of the brain and the neurotransmitters, but many of the meds that we give are definitely going to work on different neurotransmitters. So it'd be good just to get some background information. But it is not an assigned reading. So, but that is definitely a part of our biological therapies and brain stimulation therapies. So electroconvulsive therapy can be used, transcranial magnetic stimulation, vagus nerve stimulation, deep brain stimulation. And we have to remember that some of these other brain stimulation therapies may or may not be available in our own local environment. So we used to do electroconvulsive therapy at Aurora Sheboygan Memorial Medical Center. However, they no longer have a physician that does that particular treatment. So if people in our area need ECT or electroconvulsive therapy for depression, they are going to have to travel to another area, such as Milwaukee or Green Bay. A larger city would definitely have that offered. We were very lucky to have that for many years. However, it is no longer an option in our area. So I don't know that transcranial stimulation, vagus nerve, or deep brain, I don't know if any of those are offered in Sheboygan or Manitowoc areas at this point in time. But hopefully in the future, that is something that will be more available, because there are patients that are treatment resistant to, especially for depression. And they may have a great deal of difficulty with tolerating medications. Perhaps they have terrible side effects, or the medication simply isn't even effective for them. And so some of these brain stimulation therapies can actually be very helpful. So maybe you thought of ECT as something that was from old movies like One Flew Over the Cuckoo's Nest, but actually it is something that is still used, and it's used in major medical centers. It's very effective. I've seen it work very, very well when medication wasn't able to work. So if you have any other questions about that or thoughts about ECT, maybe that's something that we can talk about when we get to post-conference eventually. Okay, Erikson. So developmental theories. We definitely focus on Erikson here at LTC. I know that you know all of these stages. And so the thing to think about is if we know what stage that they are supposed to be in for their age, we can kind of take a look and say, well, are they meeting their developmental tasks or not? And why not? If they're not meeting their tasks, why aren't they meeting that? Many times I will tell you that when we're looking at our patients in clinical, we're going to say it's more than likely a direct result of their mental illness that they're not able to meet their developmental task. Or maybe they have been meeting it and now they're really at a standstill and they're not making any progress in their developmental tasks because of their illness. Or they maybe never met any of their developmental tasks past you know, industry versus inferiority. They weren't able to do the identity versus role confusion on up because of their mental illness, and maybe depending on what age they were when they became ill. So if they were ill as a young teenager, then perhaps they really haven't met too many other of their developmental roles. So that's definitely something very, very good for us to look at. And it is a very important part of our nursing assessment, and it does help us determine what types of interventions are most likely to be effective. Chapter 4, Treatment Settings. So, just a little bit of a background. In the 1860s, asylums that were first used to house mentally ill, and actually they were called insane asylums. So that's, again, kind of how far we've come. I don't believe we use that term insane as much anymore. And if we do, it really isn't a derogatory term. It really means that somebody has broken from reality and they're psychotic usually. But anyways, they have roots in the Civil War area. Only in the 1950s did we have the first antipsychotic medication. That was actually a huge breakthrough because prior to that, there really was no treatment for mental illness. Well, I shouldn't say that. There were different types of treatments, but some of them were really quite odd, such as giving insulin to somebody and putting them into a diabetic coma. They would give them too much insulin, bottom out their blood sugar, the person would become unconscious, and then they would slowly give them sugar until they brought back the person, you know, to their full level of consciousness. So there were things like that. ECT, when it first started, was actually rather inhumane because they would not use any type of anesthesia or muscle relaxant. So it was a very difficult situation. A person would have a grand mal seizure and they would have to hold them down, and sometimes bones were broken, or if they weren't holding down the person, they would fly off of the table. So there were some treatments, but they were some very odd treatments. Cold wet sheet packs, where they would take literally a wet bed sheet that was drenched in cold water, wrap it around the person, the theory being that and the person of course would be shivering, and as the sheet dried, it would become tighter and tighter around that person, kind of mimicking like being in the womb. So there were some very odd things that happened in mental illness treatment. So I know I wish I could kind of talk about that a little bit more in depth, but anyways, I'm getting a little bit off topic here. But just basically for the background, just want you to have a really good understanding that there are some really strange things that happen to people that were mentally ill. There wasn't always a good understanding. Many times people thought that patients that had different symptoms, that they were actually possessed by the devil, or somehow they were on the outskirts of society. And nowadays we really think, where anybody could have a mental illness. It doesn't matter if you're rich, young, old, poor, it doesn't matter. Any culture, any socioeconomic status, people can have illness issues. And they really didn't think of mental illness that way many, many years ago. So when the first antipsychotic medication came along, it truly was a breakthrough because people that had not I can't say again there was no treatment, but there just wasn't good treatment or effective treatment. And so now all of a sudden many people that were institutionalized could actually go back and live with their families or live in the outside world because their symptoms were under control. So Medicare and Medicaid had no funding for psychiatric care. In the 60s, and also in the 60s was the start of deinstitutionalization. So the start of the thought process that maybe people shouldn't just be locked up in a mental institution the rest of their lives for having a mental illness. Let's let them back into society. But unfortunately, many times people ended up homeless or readmitted back to care because they didn't have the funding or the placement for people. They didn't have halfway houses or group homes for people to kind of transition back into society. So it was a great idea, but it really caused some difficulties for those people. And the Olmsted decision in 1999 also deals with deinstitutionalization, and I'll talk about that more on the next slide. In 2016, there has been a drop in state psychiatric hospitals from 322 in 1950 down to 195 in 2016. So that's really significant. A large state psychiatric hospital, well, we have a couple of those left in Wisconsin, although I don't know how large Trempealeau is. I actually don't think it's all that large, but it may have been at one point in time. But Winnebago, Mendota, and Trempealeau are the three that are left in Wisconsin. And usually a large state hospital like that is a long-term facility. So people go there and they live there for years because maybe they're resistant to treatment, or their symptoms are so severe that they just can't live out in the rest of society. So it's actually a good thing from 1950 to 2016 that the number has dropped so drastically in the whole United States. So that means that we're treating people more in the community and housing them in less and less like big, large, mental health facilities that are meant to keep people for long periods of time. So the current system, we of course have inpatient care, but also many different types of outpatient alternatives. So people don't have to be in a big state hospital somewhere that's really far away from their family, and they don't have any ability to connect with anybody in their own community. So again, back to that Olmsted decision. So basically that's part of the American with Disabilities Act. So individuals with mental disabilities have a right to live in the community rather than an institution if the state's treatment professionals have determined that community placement is appropriate, the transfer from institutional care to less restrictive setting is not opposed by the affected individual, and the placement can be reasonably accommodated, taking into account the resources available to the state and the needs of others with mental disabilities. So basically, that is a positive thing for people with mental illnesses that will help them to integrate more into the community. So outpatient psychiatric mental health care. Much of our outpatient care is actually provided by primary care providers, including nurse practitioners. I went to a conference once a few years ago, and I'm not sure why I went because I'm not a nurse practitioner, but I went to this conference of nurse practitioners, and I don't even remember what the topic was, but they were all talking about how most of the time when they are seeing a patient within their own specialty areas, most of which were OB or just regular med-surg, that most of the time that they were seeing patients was because of a mental health complaint, anxiety, depression, post-traumatic stress disorder, something like that. And they really felt like they were providing that mental health care, even though that's not the specialty that they were educated in. So many times people will feel more comfortable going to their family doctor or a nurse practitioner, whatever type of healthcare provider that's more of a med-surg provider, because there isn't any stigma associated with going to see such a person. But there is stigma if you are going to see a psychiatrist. Also, part of the problem is that, well, there just aren't enough psychiatrists around, or other types of psychiatric practitioners, such as advanced practice nurses, to really accommodate that population. So many times they can't get to see a psychiatric provider in an appropriate time frame. So they may end up going to their primary care providers for psychiatric care. There certainly are specialty psychiatric care providers, psychiatrists, psychologists, again, psychiatric advanced practice people. There are psychotherapists, there are social workers that have degrees in counseling. There are just people that are plain mental health counselors that just have a counseling degree. So there's lots of different types of specialty providers, but many times it is a very difficult to make appointments. And if somebody really needs help with a problem right now, they may end up going to their primary care provider. So we have patient-centered health medical homes, community clinics, psychiatric home care, which could be provided by like visiting nurses, and there's ACT, which is assertive community treatment. So just to know that there are a variety of places that people can receive mental health care. We do have intensive outpatient programs and partial hospitalization. We do have those in the community in Sheboygan associated with Aurora. So they have an IOP which is intensive outpatient for substance abuse as well as for other mental health problems, and partial hospitalization, again, delineated for people that have mental health issues and and also a partial hospitalization for people that are struggling with substance abuse issues. So it is nice to have that little bit of separating those out, because some people may just have a mental health issue, but they don't have the substance abuse issues, and so those can be dealt with in a separate type of program. There are other outpatient venues for psychiatric care, and again, these may or may not be always available in all of our communities, but just things to be aware of. Telephone crisis counseling, telephone outreach, certainly over the internet. There are many different ways to be connected with resources, and of course, telepsychiatry. Emergency care. So we do have a comprehensive emergency service model, hospital-based consultant model, and a mobile crisis team model. These three models are basically described on page 67 in your Varkarolus, and the comprehensive emergency service model is really something that I'm very familiar with because I used to work in a large university medical center, and we had a dedicated space within the emergency room for psychiatric patients, and it was staffed by mental health nurses and psychiatric technicians, and we also had security readily available. So, and we also had psychiatrists, of course, that would come down and assess patients, but really that little section was run by nurses. We had access to social workers and other types of people that could help us with placement issues, because everybody that came into the emergency room did not need to end up being admitted. Sometimes they just needed to be set up with care. So that is one type of model. We don't have that in Sheboygan. They don't have a dedicated space and dedicated staff with mental illness specialty knowledge, but they do, patients with mental illness issues certainly can come into the emergency room and be seen and possibly admitted or hooked up with resources. But it's kind of interesting, on page 68, there's a little blue table that talks about evidence-based practice and just how much longer that psychiatric patients have to wait for care in emergency departments than other types of patients. So just kind of, just kind of interesting to look at. So 23% of psychiatric patients compared to 10% of medical patients stayed in the emergency department for more than 6 hours. So I'll let you just kind of look through the rest of that yourself. But anyways, so that's the emergency service model. Hospital-based consultation model, that sometimes is, if there is no, especially in a hospital where there is no dedicated psychiatric unit, they may have people that are on call, psychiatrists or different types of psychiatric counseling staff that may come and do a consultation and perhaps make recommendations for treatment, or even facilitate perhaps that person being transferred to a different area for care. So, and that actually, my last job that I had, again, I was a psychiatric nurse consultant in a Jewish nursing home, so I was not really considered part of the staff. However, I was somebody that would come in and do evaluations and make recommendations about the patients and teach the staff. And so that's kind of what a consultant does. You come and give your expert opinion, and you hope to help the staff to deal with behaviors a little bit differently and help the patient to be more comfortable. The mobile crisis model is considered for stabilization out in the field, and we do have a mobile crisis team for Sheboygan County. I believe Manitowoc County also has something similar. I'm not sure if it's called Mobile Crisis Team, but the great thing about this type of model is that they will meet you where you're at. So if you're at your own home, if you're out at a restaurant, if you're at a park, you know, you're somewhere or some public building downtown, they will come anywhere in Sheboygan County, and you have a person with you that's in crisis, you can call and they will come out to you and assess the crisis. They will try to stabilize things if they possibly can. If the person can't be stabilized out in the field, in their home, or wherever you are, they may make a recommendation to bring that person to the emergency room and you know, get evaluated there and possibly even admitted. If somebody needs admission, they also can help to facilitate that. There are times when people go to the emergency room on their own, or a family brings them, or police brings them, and then mobile crisis sometimes goes to the emergency room to see if they can come up with a safety plan for the person. If they can't safety plan the patient, then most of the time they will end up being admitted to the hospital. But it's just kind of a nice model as far as meeting people where they're at and really trying to coordinate care and services to try to prevent hospitalization if at all possible. So prevention strategies, primary, secondary, and tertiary. So I'm just going to go over basically what these are, and then I think I will end this recording as it's already a little bit over an hour. So, but anyways, I'm hoping as you're going through the recordings that you can stop and start at various times and that you're not sitting listening for an hour or more at a time. It might be easier to digest if you just kind of stop and start and come back to things. I can't listen for very long either. It's kind of difficult sometimes to maintain your concentration. But anyways, so I'm just going to go over primary, secondary, tertiary. You've probably heard those before, but these concepts are going to be kind of woven throughout this, the 9 mental health learning plans and also the last 3 learning plans, which are based on the community. So primary prevention is our interventions aimed towards a well population, trying to keep them well, keep them healthy, and you don't want whatever problem we're talking about, whatever type of illness, whether it's a psychiatric or a medical, we want them to not ever develop the problem, not ever develop the illness. So things that we do to keep people well. So much of primary prevention is teaching. So we can, thinking about it in a mental health perspective, we can teach people how to cope effectively. We can teach people how to communicate. So that hopefully that, and teach people not to abuse drugs and alcohol. So hopefully they won't ever get to the point where they do become ill. Secondary prevention is screening and all of the interventions that we do to help bring them back to their previous level of health. So if somebody is depressed, or if they're anxious, or if they have a psychotic disorder starting like schizophrenia, early screening can pick up on the problem, and hopefully you want to get them into treatment. And it's all of the nursing care also that can help to bring that person back to their usual state of health. Okay, so that is secondary. So it's really 2 parts. It's screening and nursing intervention. So pick up on that problem quickly and try to take care of it before it gets really out of hand. Tertiary prevention is when a disease state is permanent, it's fixed, it's not going to change, and it's all of the things that we do to try to keep that person living and functioning at a high level as possible, taking into account the fact that their illness is not likely to ever disappear. So we're trying to think, if you're thinking about maybe somebody who is bipolar and they have mood fluctuations. So tertiary prevention would really focus on having that person function as highly as they possibly can, keeping in mind that they may have some fluctuation in their mood and in their behavior. And you want to try to minimize those episodes of extreme depression or of extreme mania to kind of keep them on an even keel. So that's what our prevention strategies are all about. So I'm going to end this recording and I will start the rest of the learning plan recording very soon.